Thank you, Professor Suresh, for inviting me to this academic forum. Good afternoon, all the students. Uh, Majority of you are PG students, so my first presentation, in fact, I am presenting two topics. One is how to present a Fundus case. I'm sure most of you already know. I think the more important presentation would be my second presentation, which is what to do after your post-graduation or senior residency. So let us quickly finish with this presentation, then we come to the, this is academic presentation, and the other one is basically a non-academic presentation involving economic uh, particulars about setting up clinic and what kind of challenges you face when you go out. And I also thank, I welcome Dr. Neeraj Nagpal. He has been a great motivation force to all the medical fraternity in Chandigarh. He is a gastroenterologist and an expert in medical legal cases. So whenever any of our fraternity member has some problems, we always look forward to him for the solutions. So let us start with my first presentation, that is how to present a Fundus case. So basically, whenever you examine a case and then you have to draw the findings, you have to use cartogram, that is universal color coding. It was already pasted there in the wet lab area. That these are the diagrams which are universally accepted. These are the color codings, like you take red for hemorrhages, green for old vitreous hemorrhage, blue outline for detachment, blue outline for tears. The area within the tear is drawn as red, hemorrhages as red, microaneurysms as red, vessels in blue, veins in blue, arteries in red, disc is shown in red. Macula is depicted as a red cross in the attached retina. In a detached retina, macula is shown as blue plus sign, right? And so this you can go through. So whenever you start describing your case, you have to start from the vitreous cavity, media clarity, always. Then you go to the disc area, then you describe macular finding, and lastly you describe the periphery. So media clarity was graded by Musenblatt and was published way back in AGO 1995, and this is the grading of ocular media. That grade 0 is no evidence of vitreous haze. Grade 1 is when there is slight media haze, but optic nerve head and retinal vessels are not obscured. Grade 2 is media haze is there, but the disc and vessels are visible. Grade 3 is where the media is so much that vessels are not visible. Like here you can see this is grade 1 where disc and vessels are visible. Grade 2 where again media haze is more, but still disc and vessels are visible, but they are hazy. In grade 3 only disc is visible, vessels are not visible. And in grade 4 media haze, you can't see disc as well as vessel. So whenever you describe the case of fundus, you have to start from media clarity. Then you go to the disc area and describe the disc. So in a normal disc, you have to describe the size of the disc, whether it is normal or large or small, color of the cup, disc, neuroretinal rim, cup disc ratio, vessels on the disc surface. So all these findings you have to describe. For example, this is a case of medullated nerve fibers. So you can describe here that media is grade 0 clear, and on the disc surface you can see disc is pink in color, cup is small in size 0.2, and the disc margins are blurred, and we can see a whitish patch with indistinct borders all around the disc. So this finding fits into the case of medullated nerve fiber. So that's how you have to describe a disc. Here you can see that this is tilted towards infero-nasal direction. The blood vessels normally arise from the nasal part of the disc, but here blood vessels are arising from the temporal part of the disc. And they are first going nasally and then they are coming out. So this is situs inversus of vessels at the disc. And there is, you can see here, RP, depigmentation, and you can see the choroidal vessels shining through in the inferior nasal quadrant. So this is a case of tilted disc anomaly. So that's how you have to first describe the disc. Then you go to the macula, and in the macular area you describe whether it is normal or abnormal, and whatsoever findings are there, you have to describe the findings. For example, this is a case of ocular tuberculosis. So here you have to describe media is clear, grade 0, disc looks normal, cup disc ratio is 0.3, rim is healthy, pinkish in color, disc margin is sharp, blood vessels are normal on the disc surface. In the macular area, we can see a yellowish serpiginous lesion with indistinct borders. Overlying vessels are not obscured. Adjacent to this patch, we have pigmented healed scars all around in the macular area. So all these features are suggestive of choroiditis in the right eye. From there on, your viva will start. Okay, your diagnosis is right eye serpiginous choroiditis. Then will come the differential diagnosis, investigations required, the treatment required. So similarly, if you have a case where periphery is involved, for example, this is a case of retinal detachment. So if you are asked to describe this case, you will again start, okay, media is clear, grade 0, disc is normal. You are not a clinician working in periphery or in practice, you are a PG student. So you have to describe the normal findings as well. So you can't ignore the normal findings. So you have to describe disc is normal in size, cup disc ratio is 0.67, neuroretinal rim is healthy, pink in color, vessels on the disc are normal. In the macular area and periphery, we can see that there is evidence of retinal detachment, and the retinal detachment is coming up to center of macula. And in the periphery at 2 o'clock position, we can see a round reddish color, about 0.5 disc diameter retinal hole. So these findings are in favor. So these are the findings you have described. Then you come to your diagnosis that look here, sir, my diagnosis is left eye regmentogenous retinal detachment. Then your viva will start, okay, what kind of investigation you are going to perform and what is the treatment. So with this background now, I'll just give you one example of one prototype case that how you actually go about it in the examination. I am taking a case of diabetic retinopathy, which is very common case, and invariably you will get one diabetic retinopathy case in your post-graduation examination. So suppose this is the case you are provided with, and you have to do 90-day examination, and then you have to document the findings. So this is how you have to draw the diagram. So I have drawn the diagram as if I am a PG student, and this case has been allotted to me. So first I have to describe the findings. So here I will describe, this history has already you have taken that, okay, this is 60-year-old male, non-insulin dependent diabetic patient. Since 15 years, he complains of decreased vision in the left eye since 6 months. He is uncontrolled diabetic, his fasting sugar is 243 milligram per deciliter. On examination, this is his visual acuity, IOP, ocular movement, axis, anterior segment findings. So that part has already been done. So my talk is on posterior segment findings. So then you start with fundus. In the fundus, you will describe, sir, in this patient, media is clear, grade 1. Disc is normal in size and color. Cup disc ratio is about 0.45. Neuroretinal rim is healthy. In the macular area, there are yellowish, discrete, multiple hard exudates scattered all over the macular area. In addition, we have red dot-like microaneurysms in the macular area. Then we have blot superficial hemorrhages. Then we have whitish, fluffy lesions with distinct border, which are suggestive of cotton wool spots. And somewhere in the periphery, there is a patch of neovascularization. So all these findings we have drawn here, and these are the colors given to each finding. Hard exudates are drawn in yellow. There is retinal thickening in the macular area. So retinal thickening is drawn in blue. microaneurysms in red, superficial hemorrhages in red, neovascularization also in red, veins in blue, optic disc in red, and macula is designated as a plus, given a plus. So these are the findings you have to describe, and this is how you have to document and show to the examiner. So I have this chart with me that you can take after the talk, and then you can just take a photograph for your reference. So then next question examiner will ask you, now tell me what is your diagnosis. So time does not permit me so that we can have an interactive session, like I can ask you. So I'll ask myself and answer myself as what are the possible questions and how I have to answer the question. So if I'm asked what is the diagnosis, so my diagnosis would be, sir, this is the case of left eye proliferative diabetic retinopathy with diabetic macular edema, right? So the next question immediately he is going to throw to you is, okay, what are the findings which are suggestive of diabetic retinopathy? So then your answer would be, see here, there are hard exudates, microaneurysms, superficial hemorrhages, cotton wool spots, neovascularization, and the patient is a diabetic. So all these findings are suggestive of that this is a patient of proliferative diabetic retinopathy with macular edema. So next question would be, how come these lesions? What is the pathogenesis of these lesions? How do microaneurysms form? What is the mechanism of hard exudates, cotton wool spots? So microaneurysm, because there is parasite loss in diabetic retinopathy, and there is outpouching of endothelial cell capillaries. So these outpouchings form microaneurysms. And how do hard exudates form? Because in diabetic retinopathy there is loss of parasite. So there is the capillaries become porous and they start leaking, and the plasma starts leaking into the macular area, and the plasma contains lipids. So these are aggregation of lipids which are giving you these yellow appearance is basically accumulation of lipid deposits which are labeled as hard exudates. What are cotton wool spots? These are basically in diabetic retinopathy also there is occlusion of, not only there is leakage, there is also occlusion of, because platelets aggregation is also there. So there is occlusion of capillaries and arterioles leading to thrombosis. So once one arteriole is thrombosed, so in a localized area there is nerve fiber layer ischemia, and this is the accumulation of nerve exoplasm that leads to formation of that whitish patch, which is called cotton wool spot. So cotton wool spot is basically ischemia in that nerve fiber layer, where the nerve fibers are passing through and there is exoplasmic stasis. So next question would be, okay, what are the possible investigations? What investigation you would like to carry out? So your answer would be FFA and OCT. Which one will be the preferred investigation? FFA or OCT? Anybody? FFA. See, the 15 years back when OCT was not there, anti-VEGF injections were not there. So my answer would be, sir, OCT would be the investigation of choice in the case of diabetic macular edema, right? Reason being, with FF, when anti-VEGFs were not there, OCT was not there about 15-20 years back. Then with FFA, you used to see that where is the leakage in the macular area, whether it is focal or diffuse. So if it was a focal leakage, we would carry out focal laser. If it is a diffuse leakage, we would carry out grid laser. But nowadays, nobody is following that protocol. Nowadays, we have to find out whether it is center involving macular edema or non-center involving macular edema. And to define that, you require OCT. So investigation of choice would be OCT. In OCT, if the macular edema is within 500 micron, it would be center involving diabetic macular edema. And here the treatment of choice would be anti-VEGF injection. If macular edema is lying outside 500 micron, then it is a non-center involving diabetic macular edema. So here treatment of choice would be focal laser. So investigation of choice would be OCT, so that we can define whether it is a center involving or non-center involving macular edema. So then they will ask you, okay, if it is a center involving diabetic macular edema, how you are going to manage? Then your answer would be anti-VEGF injections. Which anti-VEGF injection you will prefer? So you can say we have the choice of Avastin, bevacizumab. You will never take trade names. You will always speak about salts. So you will say not Avastin, Lucentis, Eylea or Paginax. You will always say, sir, we have the choice of bevacizumab, ranibizumab, aflibercept and brolucizumab. Which one would you prefer to begin with? So you will start with anyone or there are some guidelines. So your answer should be, sir, the largest study which has been carried out for the management of DME is Protocol T by DRCR network. So Protocol T tells you that bevacizumab, ranibizumab and aflibercept, all three are equally effective if the vision is better than 6/12. But if vision is less than 6/12, then probably aflibercept is better than Avastin or Lucentis. So, and how many injections? Next question would be how many injections you will give. Then you will say 3 monthly to begin with, and then depending upon response, you will carry out the treatment. So monthly for 3 months has to be standard treatment in any case of DME. It is not that you are going to stop at 1 or 2. No, that is wrong. Protocol T tells you that it has to be 3 consecutive injections. Any DME which is center involving. After 3 injections, if there is still residual edema, you will continue with the injection. If after 3 injections there is complete recovery, stable, then you will give injection on PRN basis. Right? Next question would be, when will you switch over to other? When will you say the treatment is not working? What is the failure? Or when will you switch over to Ozurdex? If with 2 consecutive injections there is no improvement, so that means this molecule is not working. Suppose you are giving with bevacizumab and with 2 consecutive injections there is no improvement, then you will change your treatment. So you can change treatment to which molecule you will choose. Either you take higher molecule of anti-VEGF category, you take either aflibercept or you take brolucizumab, or you change to dexamethasone implant, which is called Ozurdex. Trade name is Ozurdex, otherwise it is dexamethasone implant. So this way your Viva will keep on going in different directions. So you have to be ready. There are 100 more questions that can revolve around this discussion. So I'm just giving you example how your Viva will. Then your Viva will proceed to what are the mechanism of actions of anti-VEGF injections, complications, success rate, when will you do surgery, what will you, how do you do PRP, what are the parameters for focal laser, what are the parameters for PRP. So all these things you have to know. Right? So suppose somebody is telling me the difference between focal and PRP laser. So focal, then you should tell focal laser is the spot size is 100 micron, power is 100 milliwatt, duration is 0.1 second, and the end point is branching of microaneurysm or darkening of microaneurysm. What are the parameters of PRP? The spot size is 500 micron. In focal it is 100, here it is 500. Power is about 200 to 300 milliwatts. Duration is 0.2 second, and the end point is dirty white burn on the retinal surface. How many spots you give in PRP? It is done in 3 sitting, about 1500 to 2000 spots. So all these things are given in your books, and these are the questions which will be asked. So I think I should stop here, otherwise discussion can go on and on. Any questions regarding this? So this is how you have to proceed with a Fundus case.